Dear audience, let me introduce my PhD topic, which is the role of alternative treatment methods in lung cancer. My name is Shahar Adar. I am a first-year PhD student and fifth-year medical student. Together with my team, our vision is to increase the quality of life and the survival rate of patients with lung cancer. And we are planned to do so by conducting a survival analysis that measure the different treatment methods for the disease. We have two specific goals. Both of them are associated with different treatment methods of lung cancer. My first project, investigating the safety and efficacy of different treatment methods of local regional therapies in early stage non-small cell lung cancer, and we will conduct this project by using systemic review and meta-analysis. So a bit of a background. Every year there are 2.2 million people which are newly diagnosed with lung cancer. That actually means for us that every day there are approximately 6,000 people which are newly diagnosed. Of those 6,000, 20% are diagnosed with early stage of the disease. For those patients, there are 3 definitive local regional therapies. We have surgery, ablation therapy, or radiation therapy. Nowadays, surgery is the gold standard. And for those patients who cannot undergo surgery, there are less invasive or minimally invasive techniques such as ablation therapy or radiation therapy, which are offered. There are a few disadvantages for surgery being a gold standard. First of all, the longer hospitalization time and the longer rehabilitation time of patients undergoing surgery is way higher than the minimally invasive technique. Additionally, patients which undergo, additionally, up to 24% of the patients that needs to undergo surgery refuse to do so out of fear of complications and other personal reasons. That is why we would like to investigate whether ablation therapy or radiation therapy are non-inferior or can be an alternative to surgery. Our clinical question: can lung ablation or radiation therapy provide a viable alternative to surgical resection? And we hypothesize that either ablation or radiation therapy are non-inferior to surgery. And by investigating this topic, we could provide a better treatment personalization for the patient. So the patient could get the best treatment that they can have. We conducted this search key. It has 3 domains. The first domain is our population, patients with early stage non-small cell lung cancer. Second domain is the surgery, which is nowadays the gold standard of treatment. And the third domain is either radiation therapy or ablation therapy, which are alternative methods to surgery. We conducted this search key in 3 databases, and so far we received around 9,000 hits. And after duplicate removal, title abstract selection, and full text selection, we collected 162 articles. After that, we did a citation tracer, which again, after duplicate removal, title abstract selection, and full text selection, we included an additional 10 articles. Now we finish with the data extraction or the gross data extraction. However, we have a lot of Kaplan-Meier curves. Those are extracted manually, and we will completely finish with this phase at around 2-3 weeks. Regarding my second project, investigating the safety and the efficacy of lung cryoablation therapy and surgical resection for the definitive treatment of early stage non-small cell lung cancer. And I will choose the methodology of randomized controlled trial to investigate this topic. So as I was saying, surgery is now the gold standard of treatment for the disease. However, due to longer hospitalization time and longer rehabilitation time, around 15 years ago, there was a significant development of an alternative technique, or more precisely, the ablative technique, which I mentioned before. And there are no randomized controlled trials which currently compare patients which undergo surgery or cryoablation. Cryoablation therapy is a specific type of ablation, and during this procedure, with the aid of a CT device, the physician insert a probe, the so-called cryoprobe, into the patient's chest. After that, the patient or the doctor decreases the temperature of the probe, resulting on a freezing of the tumor itself, resulting the so-called the ice ball. The cold temperature destroys the cell and all the enzymatic activity inside of it. After that, the physician increases the temperature of the probe itself, resulting in the formation of a hypotonic solution. That hypotonic solution results in explosion of the cell and so-called destruction of the tumor. In picture A, we can see that there is a peripheral lung tumor, and in picture B, we can see the actual ice ball, which can be visualized during the procedure itself. Our aim in this study is to investigate the safety and the efficacy of lung cryoablation versus surgical resection. A clinical question: can lung cryoablation provide a viable alternative to surgical resection for the treatment of early-stage non-small cell lung cancer? We hypothesize that cryoablation would be non-inferior to surgery. And again, by investigating this topic, we could provide a better personalization for the treatment, so the patient will get the best treatment that they can have. I would like to summarize my two projects. Both of them are investigating the safety and the efficacy of different treatment methods in lung cancer. My first project will focus on all of the local regional therapies, so ablation, radiation, and surgery, whereas the second one, precisely, we will investigate specifically the cryoablation and the surgical resection. I would like to finish my presentation with a quote of Patch Adams: "You treat a disease, you win, you lose. You treat a person, I guarantee you'll win, no matter what the outcomes." Thank you very much.
Excellent presentation. Thank you very much. So now the room for questions. Everybody has some options for ask.
Thank you. It was a nice presentation. I'm actually a dentist, and I was wondering about your first project regarding that. You've mentioned there were like 4 or 5 or 6 outcomes.
Yes. Yes.
And I was wondering if have you considered to get more outcomes related to lifestyle factors? I mean, like after the surgery, how do the patients feel? So
let me answer your question with more. Let me reorganize the question, if I may. So, what is safety and efficacy? What do we mean by investigating safety and efficacy of a specific treatment type? That would be like, how do we define if it's safe and effective? And we actually use we consider 3 different factors. We have the patient factor, the disease or the tumor factor, and the treatment itself. When we're talking about the patient, we would consider whether the patient has some kind of a comorbidity. So what is background, the age, the fragility factor, his lung function. For that, we have the overall survival and the cancer-specific survival outcomes. This is the patient part. When we are talking about the disease itself, we can check or we can look for different recurrence or the aggressiveness of the disease itself, how it metastasizes. What is the different time between the disease when it is localized until it metastasizes? This is the disease factor. When we're talking about the treatment itself, we can mention the perioperative mortality, the 30 days mortality, the 90 days mortality, what is the complication rates and what are the complications. And all in all, we can produce a significant and comprehensive analysis that can help better the doctor and the patient to decide which treatment they prefer based on their current data. Was that?
Okay, and patient satisfaction was also mentioned in those articles, or?
So, okay, so when we're talking about the,
quality of life, or how was it mentioned?
So yeah, some articles did mention quality of life. However, that was not the scope of the outcome that we are looking for. When we are actually looking of patient satisfaction, in my opinion, I would say that a patient have a choice or most of the patients have a choice. Which treatment would they choose? Ablation, radiation, surgery? What do they gain? What do they lose, theoretically, from the treatment? So would they prefer a better overall survival or a more effective treatment, or would they prefer a less invasive, however, recurrent treatment? So those in the patient side, and that was not the scope or the major scope of the research itself that we do.
Thank you.
Okay, thank you. It was an excellent presentation. And my question would be that what kind of articles did you include at your first project, and how would you overcome the heterogeneity?
So during our search, we included, or there are only available retrospective cohort studies. So we don't have, there are no randomized control studies. And to overcome this challenge, we use two different or three different statistical methods. We have the so-called the subgrouping. We use the propensity score match, so we can see what are the factors that are matched between both groups, either ablation or radiation or surgery. And we can use the multivariate analysis with the Cox regression. And that gives us the adjusted hazard ratio. And by using those, we can overcome the confounders that are quite different between the populations.
Thank you.
Okay, so in your answer, you mentioned subgrouping. What kind of subgroups do you want to make?
Thank you for your question. So we're talking about subgrouping. As I saw so far, we have a few different ways to look at it. We can look at it about the patient perspective and the treatment perspective. If we're talking about the patient perspective, there are patients which we can say are more high risk or low risk. They are patients which are older or younger. There are patients with peripheral tumor or central tumor. Those we can do subgrouping and see which treatment is best for each group. Also, we can divide it for the treatment subgrouping. We can choose more invasive surgery, such as lobectomy, pneumonectomy, or we can choose less invasive surgery, for example, the video-assisted thoracoscopic surgery, for example, sublobar resection, which are less invasive and reserve more lung function. By doing those subgrouping, we can actually see which population gain more from which treatment.
Thank you for the presentation. I have a question about your second project, your randomized control trial. Would you consider grouping the patients as their prior smoking states?
Yes, thank you for your question. So if we're talking about the smoking itself, also for the first project, smoking is a huge risk factor in the lung cancer population. It results in, so we can say that there are guidelines that say that patients who are smoke and for how many years or pack year smoke, the most risk for the procedure itself. So I would say yes, but first of all, we should finish and get the conclusion for the first project, and based on that, we would be smarter to conduct the second project, and of course, also based on subgrouping with the smoking.
Thank you.
Shahar, excellent presentation. A very small, short question. Why do you think there are no randomized controlled trials so far? What's stopping people from making randomized controlled trials?
That's actually a great question. There are three randomized controlled trials that compared with surgery and radiation, and those trials failed to occur, not with the ablation, but rather with the radiation. And they failed because there was no enough patient compliance. So when we are doing a randomized controlled trial and we say to 50% of the patient, okay, we will give you treatment A, and we take 50% of the patients and we say, okay, for those, we will give a different treatment. The patients, don't know which is best, you need to convince them. You need to convince them that they are non-inferior to one another for a more comprehensive randomized controlled trial to occur. And that is one of the major advantages of this study. By providing significant data, hopefully we will provide significant data, we will make future scientists to have those trials. So we will be able to help them make a randomized controlled trial and have a more scientific, significant data.
Very short question, or maybe just a comment. So it's a very nice explanation and response to this question, but you know, it might be not the actual reason why they are not done. I don't know why there are not enough RCTs, but I would be very cautious to conclude in the end whatever you find, whether one is non-inferior to the other, because these are just completely separate populations, and the indications for the second-line therapies are not the same as for the first-line therapies, obviously. So just be very careful when you conclude.
Yes, of course, I would like to add that I absolutely agree, and I think personally, after seeing the data, that gross analysis between ablation, surgery, and radiation, it doesn't make any sense, in my opinion. However, no, but after seeing the data, however, by doing subgrouping and by doing matching and using the adjusted hazard ratio, the data will be more apparent to the reality. So when we match the patient, then we can say, okay, so those patients which have the same lung function, same age, same comorbidity status, those patients are more likely to have the same results. And based on that, it would be better to produce a randomized controlled trial.
These are very, very nice final words. Thank you very much, Shahar.
Thank you.
Excellent.